quite a few of you are streaming in. So I just want to start by saying hello and a warm welcome to all of you. I know that, like me, there are many people logging from all over the world. I'm in Hong Kong right now, examining some young resident doctors here. Um, but today's a special Dean's Grand Round, not only because it's the last one of the year, and we've had a series of successful Dean's Grand Rounds, and the special one is because it's President Lade who's here, and our honorary fellow Henrietta Bowden-Jones, who's actually going to be leading the Grand Round. So again, a big thank you to you, Etta. Big thank you to you, Lade, for being a part of the Grand Rounds, which have been so successful. And as always, Deepa, big thank you to you for being the lead for the Dean's Grand Rounds. You led them really successfully. And over to you all. We've got a great panel. I'm looking forward to the discussions. So over to you, Lade.
Brilliant, excellent. So, welcome everybody. And although there are, I think, more and more people are going to be coming online, there's a total of over 1,000 people have signed up to watch this Dean's Grand Round, which is pretty amazing, actually. And I think that goes to show how important this area is and how much interest there is. And probably quite a lot of us don't feel that confident, so we want to know what the cutting edge is in terms of gambling disorder. And we have got a fantastic panel who are going to help us understand that. First of all, just some housekeeping. Please remember, if you've got a question, put it in the Q&A, not the chat. If it goes in the chat, it's probably not going to get answered. Put it in the Q&A, please. If we can't answer the question during the talk, it'll be answered at the end of the webinar. If you've got any technical issues, please let us know in the chat and a member of the team will assist you. And the chat, of course, is open for discussion and comments. But of course, we are all very kind professionals and people with lived experience. So let's keep the comments suitable, respectful, and just so you know, if the comments are really inappropriate, we'll probably delete them. And if it's really, really inappropriate, we'll probably remove you from the webinar. Anyway, and for those who want them, you get a certificate of attendance, which will be sent out next week. And also the recording is going to be available, so you can either watch again, or if you weren't able to watch live, you'll be sent an email with a link to the recording. So our panelists, we have Professor Sam Chamberlain, Professor Henrietta Bowden-Jones, Mr. Steve Watts, and Dr. Konstantinos Ioannidis. Actually, I might have got that a bit wrong. Sorry, Konstantinos. Anyway, Sam Chamberlain is a professor of psychiatry at the University of Southampton and honorary consultant psychiatrist at Hampshire and Isle of Wight Healthcare NHS Foundation Trust. He founded and directs the NHS Southern Gambling Service, and that's a specialist tertiary clinic for impulsive compulsive disorders. And of course, Sam's research focuses on understanding the biopsychosocial underpinnings of these conditions and developing new treatments for them. He's one of the top 10 leaders globally for research into gambling. Etta Bowden-Jones is a consultant psychiatrist who specialises in addiction psychiatry. Her work has been so influential that she's been awarded an OBE for services to addiction treatment and research. And she was actually appointed NHS England's first ever national clinical advisor on gambling harms, and that was in September 2022. And she regularly advises the UK government on matters relating to gambling disorder, gaming disorder, and mental health. And in fact, in 2008, she was the founder of the first ever NHS clinic to treat gambling disorder. And there are now 15 clinics nationally developed from her original gambling one. Mr. Steve Watts has lived experience of dealing with a family member who developed an online gaming addiction. That escalated into a gambling disorder. And that empowered him to set up a charity, GamFam, please look it up, in 2020. Prior to that, he's worked in education for 20 years at secondary school. And at that time, probably like many of us, had no idea about the impact that gambling harms can have on individuals and families. And after reaching out to lots of frontline services, it wasn't until him and his wife attended a peer support meeting that he really found some hope and empathy. And finally, Dr. Konstantinos Ioannidis is a consultant psychiatrist and clinical lead of the Southern Gambling Service, honorary associate professor in the Faculty of Medicine at the University of Southampton, and he specialises in behavioural addictions and, again, gambling-related harm and digital mental health, which of course is becoming increasingly important. He leads the multidisciplinary regional NHS service, collaborates widely across academia, policy, and public health. And his research really looks at neurocognitive mechanisms and socioeconomic determinants of gambling harms. And his work has a growing national impact on thinking about the evidence base and how you can use that to develop services and guide improvements. And so I'm really looking forward to this webinar, as I'm sure you all are too. And I am going to hand over now to our first speaker, who is Professor Sam Chamberlain.
Thank you very much for that kind introduction, and welcome to everybody. Thank you for joining. Bear with me while I get my slides loaded up for you. Usually always takes a bit longer than you expect when the pressure's on, right? Could someone just let me know if they're able to see the slides okay?
We can see your slides, Sam. Thank you.
Great, thank you. So always ask when you're watching this kind of symposium about gambling disorder, whether any of the speakers have conflicts of interest, because of course there's a lot of industry influence out there, including over research. So I don't have any conflicts of interest in relation to the gambling or gaming industries, and I know that the other speakers don't either, but I'll leave it to them to mention that themselves. So when we're thinking about gambling disorder, I think it's useful to look at one of these images here from Casino Royale, so one of the James Bond films back in the 1960s. You can see that the gambling, they're at a casino and it's presented as a very glamorous activity. And of course, that's what industry wants us to believe. But as we'll see, many people develop problems from gambling. You can see in this image, there's a lot of alcohol being consumed. There's a lot of smoking. And that really emphasizes the point that we know, all of us know certain substances have addictive potential, right? But the same is true of some certain behaviors. And in fact, there's case reports and descriptions of gambling addiction dating back to antiquity in ancient literature. But of course, it's only relatively recently that it's been sort of a recognized medical condition as such. So some people can gamble without significant negative consequences, but many people do develop a problem. Now, gambling disorder is the medically recognized condition. So this is clearly defined. It was previously known as pathological gambling, and you may also hear it referred to as gambling addiction. This is listed both in the Diagnostic and Statistical Manual and in the World Health Organization's International Classification of Diseases. But it's overlooked and undertreated. Sadly, best estimates from the research are that less than 10% of people with this condition ever even get an assessment that's appropriate, let alone evidence-based treatment. How can we define it? Well, we look to the manuals. I've shown here the ICD criteria because they're kind of easier to follow, but people also use the DSM. There's pros and cons to that. So for gambling disorder to be diagnosed, a person needs to have been experiencing repetitive gambling, typically over the last 12 months or longer, that leads to impairment. And what we see is a loss of control over the behavior. We see increasing priority to gambling over other areas of life and other activities. And we see a continuation or an escalation despite the negative consequences. We can all screen for gambling disorder without being experts. There's many screening tools out there that have been evaluated scientifically. We shouldn't probably be using such screening tools in general population settings. They're not really ready for that yet psychometrically, but we can use them in the context of populations where gambling disorder is more likely. So we can be using these in our psychiatric settings, outpatients, inpatients, A&E, general practice, these can be used. So this is a nice easy screener, 2 items. So in the past 12 months, would you say you've been preoccupied with gambling? Have you gambled longer with more money or more frequently than you intended to? If a person answers yes to one or both of these, then you should be thinking about either doing a proper diagnostic screen, because gambling disorder may be present, or referring to a service that can do that for you. We need to bear in mind that although this symposium is focusing mainly on gambling disorder, that is the tip of the iceberg. It's the severe tip of the iceberg, granted, but we also have a lot of people out there across the world who don't meet the full diagnostic criteria at the present time, but they do experience negative consequences from the gambling. And this is typically referred to as harmful gambling or at-risk gambling. This image here, this is showing you different types of gambling. And for those different types, the proportion of people who have a gambling disorder. So you can see that it varies depending on the type of gambling being considered. There's a couple of key points here. One is if you look at EGMs, so this is electronic gaming and gambling machines or casino games, there's a particularly high percentage of people with a gambling disorder. So these are probably relatively sort of problematic types of gambling, quite strongly linked to addiction. But the other point is nothing seems benign amongst these categories. You can see that even lotteries are associated with gambling disorder in 0.5 to 1% of people, which is a lot of people globally. You might see on television the National Lottery being presented as this wonderful, happy thing that helps lots of people through charitable work. In fact, that is a type of gambling often shown alongside other more harmful types, and it could act for some people as a gateway to other more harmful types of gambling. How common is gambling disorder and at-risk gambling? So we've got different numbers we can look at. None of them in the UK are perfect, although the UK is probably ahead of most countries in trying to measure it. But these are some data from a few years ago. If you look at the top panel, this is representing the population of Great Britain as 100 people. You can see around half of those people are coloured grey. They don't gamble, so around half the adult population doesn't gamble, but the other half does. So gambling is a really common activity in Great Britain. You can see that around 5 people are coloured orange and red, and these are people with gambling disorder or problematic gambling. So that's up to 5 in every 100 people, 5% of the population. That's a lot of people negatively affected. The bottom panel is perhaps more concerning. So this is looking specifically in young people aged 16 to 24 who gamble. So it's a sub-analysis. But in those young people who gamble, up to 20 in every 100 already have a problem. Okay, so that's pretty shocking because these are people at critical stages of their development, trying to form careers, relationships, and they're already experiencing gambling disorder or at-risk gambling. So I think we should collectively be really concerned about that. What about other countries? We don't have great numbers globally. As I mentioned, even in the UK, we don't have great statistics, but there was this systematic review by Heather Wardle and colleagues. So they were looking at on this slide, it's rates of gambling, so not gambling disorder per se, but rates of gambling in different countries. You can see for large parts of the world, it's shaded grey. We don't have good statistics at all. In the parts of the world we do know about, we see a lot of the population are gambling, and of course it varies depending on the region, but it's not unusual to see 50 to 70% of the population gambling where it's been examined. And of course, that means there will be a lot of gambling disorder in those countries as well, even if it's not well measured yet. What about comorbidities? So if we look at treatment-seeking populations, we see really high levels of comorbidity. Up to 75% of people presenting with gambling disorder and seeking help will have at least one mental health comorbidity. And this is based on good study, good work by Nikki Dowling, where she pulled together all the global evidence from the research. What comorbidities are most common? You may expect some of this, I don't know, but we see a lot of anxiety, depressive disorders, not surprisingly. We see a lot of other addictions, alcohol use disorder, nicotine dependence, and we see other impulsive and compulsive conditions such as attention deficit disorder, obsessive compulsive disorder. A lot of gambling now, you'll appreciate, is over the internet, and therefore there's a big overlap with what we might refer to as problematic usage of the internet. So that's a bigger umbrella construct, if you will, rather than an official disorder. So just be mindful in gambling disorder, we've got these massive overlaps of comorbidity. And if we don't identify the gambling disorder, probably the depression's not going to get better, for example. It's going to impede other treatments for these other conditions that we're seeing day to day. So that can be a real problem. Consequences. I know we'll be hearing more about this from the other speakers, including from a lived experience point of view, but I quite like this image in terms of just giving a simple overview of what domains can be affected. Gambling disorder does affect people differently, but in general, lots of negative personal consequences. The comorbidities can occur: suicidality, poor physical health like obesity, cardiovascular disease, insomnia, so sleep disorders, financial hardship, high levels of debt, losing your home, losing your livelihood, legal consequences like bankruptcy, or some people with gambling disorder may also embezzle or steal from others because of the strength of the addiction. Interpersonal, this is just terrible. We see this all the time in clinic, like it completely breaks down families. Often loved ones don't know until very late in the addiction that there's a problem. It's often stigmatized and hidden. It's terrible. Loads on other community services. So if people are presenting in homelessness or in crisis in A&E, say with suicidality, that has a knock-on effect for wider society. And then we've got effects on academic achievement, so worse academic outcomes, higher levels of absenteeism from work, and job loss. So I hope I don't need to sort of impress upon you too much more like why this is so important to address. Now, obviously in a 15-minute talk, I'm not going to be able to talk about every single potential kind of causal factor, but being in the Royal College, we think in terms of biopsychosocial approaches, we need to be comprehensive. We need to think about all the different factors rather than just focus on one bit of it. So we should think at the level of the individual. Were they exposed to gambling early in life? Do they have a genetic predisposition? Do they have high levels of trait impulsivity, so a tendency towards reward seeking that might predispose them? We can think at the level of the families. So, is gambling normalized? Is it around? Is it acceptable? What about the relationship between, for example, the children and the parents? Is there an open dialogue about gambling and other potentially problematic behavior, or is it kind of very much a hidden, non-disclosing kind of relationship or set of relationships? Community. So are there gambling adverts everywhere? Where are they? Is gambling happens in schools and other local places? Is it accepted? Is there deprivation? We know that gambling is linked to higher deprivation. And then last, but by no means least, the level of society. So this is what the government does. Are they legislating against what the gambling industry is doing to prevent harms? What are the gambling industry companies doing? Are they advertising addictive products and developing those? Are they showing adverts that young people will be exposed to, even though legally that might be hard to prove, for example? So all of these factors come to bear, essentially. And perhaps we'll be discussing some of these a little bit in the Q&As, depending on what people want to talk about a little more. But obviously it raises a lot of issues for all of us. Just as a sort of slight sidestep, and very briefly to mention that most cases of gambling disorder, it's complex, it's multifactorial, but sometimes medication can directly cause gambling disorder, even in people who've never had it. We see this in clinic. And the culprits are often dopamine agonists, such as pramipexole and ropinirole. These can be used for neurologic conditions like restless legs, or sometimes for Parkinson's disease, for example. Another medicine you'll perhaps be more familiar with on a day-to-day basis, aripiprazole, can cause gambling disorder for some people. Not everybody. We don't know why some people develop gambling disorder from these drugs and not others, but it's important to be aware of. I mean, the typical thing we see is someone's developed gambling disorder from these drugs, and it's never been mentioned to the person by their GP or their neurologist that can be a potential side effect. And often the GP is unaware. So by being aware of this, you can do a big service to patients, because you might actually detect a treatable cause of the gambling disorder in some people. Professor Bowden-Jones will be talking about the national situation, so I'm not going to go into detail, but just to say our particular clinic, we opened 2022. It was a really exciting opportunity, thanks to Henrietta, actually, whose work led to these opportunities. And so we set up our clinic. We're based in Southampton. We're down by the docks, you can see on the map. Our unit, it's co-located and collaborative with the University of Southampton, so we make sure that research informs practice and vice versa. And this is the view from more or less opposite my office. So this is no coincidence. We know that gambling venues tend to be put in relatively deprived communities. So Southampton does have pockets of deprivation as a kind of coastal community that's lost some of its industry. We see similar patterns elsewhere. And indeed, that's shown. These are some data collected by our other speaker, Konstantinos Ioannidis. So these are looking at referrals to our service from when we opened. So the first set of referrals, and it's looking at where they come from. And the graph is showing where we receive an excess of referrals geographically. So the stronger the red colour, the higher the level of referrals. And you can see high levels in our deprived rural and coastal communities, such as Medway, Southampton and Portsmouth, for example. And we also see associations between where these referrals come from and where the gambling venues are. So if you're near a gambling venue, if there's one in your area and you've got a short drive to the venue, we're more likely to be getting a referral, probably because actually those venues are causing the disorder, but of course that's harder to prove. So turning now to treatment approaches as the sort of last part of my overview.
Sam, you've got about a minute and a half.
Cool, I'll be brief. So evidence-based treatments, talking therapy or medication. The bread and butter is psychotherapy, typically cognitive behavior therapy. There's a couple of extra techniques we can add in, like motivational interviewing and desensitization, which we could talk about in the Q&A if people are interested. Usually we'd be looking at 6 to 8 sessions, so a total of 8 hours. But there's we can discuss the dosing. It's not that clear because sometimes even very brief interventions can help. And that's been shown in research, including with benefits up to 1 year later. There's no licensed medication, but there are medicines with an evidence base. Naltrexone and nalmefene are the two that are most widely used and best evidenced, and these are opioid antagonists. And we know that these are effective from randomized controlled trials. And if you're interested, Konstantinos has done a paper doing a systematic review and network meta-analysis to look at all these drug treatments and rank them. And you can see nalmefene and naltrexone come out best, but they do have high levels of side effects. So we need to be thinking about treatment trials for other medicines. So just to conclude, hopefully I've shown gambling disorder really important, common, often overlooked, undertreated, many negative consequences, complex causal pathways. We do have treatments, but we need more. There are big research gaps, which we may hear about and discuss later. Thank you very much.
Excellent, excellent. Thank you, Sam. That's a wonderful overview, really good introduction. So I'm going to hand straight over now to our next speaker, who is Henrietta Bowden-Jones.
Thank you so much. Can you hear me okay?
Yeah.
Great. I'm just going to test to see if I can move forward. Great. Then the first thing I'd like to say is thank you to Sam for such a brilliant, brilliant speech. And the fact that it was happening in the first place, that Sam has spoken before me and Konstantinos will speak after me, is an indication of where we are at with gambling disorder in this country. After 20 years, almost 20 years actually, of being alone in this field within the realm of the college, giving talks, doing podcasts, giving webinars, all sorts of things. I now have, two extremely competent, highly ambitious colleagues who are going to really lead on the pharmacotherapy, on the randomized controlled trials, on making sure that we really further this field into what is now really a global first. And I'll tell you why we now have the eyes of the world on us, because we are the only ones with this network that I'll tell you about. But just before I start, I would also like to say that when you show the picture of the casino opposite your office, it does remind me of the fact that the National Problem Gambling Clinic was based in Soho for many years. And at some stage, to our great anxiety, the biggest casino in England, the Hippodrome, opened at Leicester Square, which was the tube station where our patients needed to come out if they were going to come for treatment. I cannot start to tell you how much that impacted on relapse rates and attendances at a time when there was no online virtual treatment. They literally had to get there. And so many of them never got to us, although they had saved up their money, got to London, stopped in the casino. Okay, so that's just a by the by. But this is a momentous moment, I think, for the Royal College of Psychiatrists, who has been a real bastion of support for myself, for gambling disorder, and the fight against gambling harms from the beginning. So I'm very, very grateful to the college as well. No conflicts of interest. And I just wanted to touch one more time on the gambling disorder. It is a significant percentage. The latest one from last year, 2.7%. We know gambling harms an enormous amount of people, and even more so, there are 7 to 10 people get really harmed by any one person with a gambling disorder. So if you do your calculations, it is very widespread. And nowadays, whoever you talk to about gambling, someone will say, I know someone with a problem. I have a relative with a problem. And we are really campaigning against stigma in relation to gambling. We need to treat it like any other illness. So people can tell you they have a relative with a problem and you can tell them what to do about it. But even now, there remains a layer of shame and stigma attached to gambling disorder that is no longer experienced in relation to alcohol, for example. I'm not saying there is no stigma in alcohol, but it's so much worse for gambling. So be aware. Often, if you don't ask, you will not be told. This lovely building is the place where we run the National Gambling Clinic from. It also houses the National Centre for Gaming Disorders, which I founded in 2019 under the same NHS money pot, which I'll tell you about. And we also have the children's services. And this is really important. We are on a mission to build the children's services. We know there are at least 80,000 children with a problematic, who should not be gambling at all, but who are gambling problematically. And I want to make sure we eradicate this completely in all sorts of ways. But one way is to make sure that if anyone finds children gambling, they come and see us as soon as possible. So as Lada said, before 2008, there was no National Health Service to treat gambling disorder. And when I started the first clinic, I thought it would be very quick, but it was not quick at all. It took me a long time. It took me 11 years and thousands of referrals with an underfunded and isolated system before the 2019 implementation occurred. Sam touched on the interventions. I will not dwell on these, but the 2019 long-term plan did allow the expansion to 15 clinics and included the young people and the gaming. And we now have hundreds and thousands of people who have referred themselves for gaming disorder. And we can talk another time about the interface between the two, which is an interesting one. So then we had a 5-year period during which time we were building the clinics, we were finding people who could run them. We were understanding more about the national distribution of harm, and more work will need to be done on this. But what we do know is that there are plenty of patients to go round. And this is very sad, but true. Gambling disorder is ubiquitous. It happens in all sorts of social milieus, and it happens all over the country, all over the world. And I was speaking at the WHO meeting yesterday on gambling disorder. This is a problem with high levels of presentation and pathology across all countries that we were hearing about, including the ones in which gambling is illegal. It's just harder for them to come forward. Here is just a map of the fact that the clinics are regionally distributed, and integrated care boards are going to be distributing the money. Not much time to tell you anything about the design principles, but I would like to say independence from industry is key. And peer support plays a really big part. We are very, very keen to justify all the money that this levy has given us, which I'll tell you about in a minute. Justify we're doing the best we can in the most evidence-based way. There is not enough research in gambling disorder. We cannot tell you that what we're doing is the best that exists, that would exist, because we don't have enough RCTs. But from the evidence we have, and Konstantinos has done great work, and he'll tell you about the NICE guidelines, we know that we are delivering the best we can to our patients. A quick word about being a national advisor on gambling harms. It was a new role. It is a very political and corrupted world, if I may say this. There's a lot of conflict of interest around. The industry has their hands on Parliament, on politicians, as you read about in the papers, and it's so hard to get to the politicians with the right evidence base and the right concerns when so many other people are distributing tickets to football and to concerts. So, transparency, accountability, independence, and a public health approach are all key vital issues to support. So you will have heard about the levy. Some of you may not, but we were successful after the first time I started talking about the levy was 16 years ago. And I remember posting on Twitter posts about what I want for Christmas from Father Christmas was a levy. This was year on year. Eventually we got it. We got the white paper in 2023, and it was implemented in early 25. And now this money is flowing through the right systems. It's 90 to 100, it's actually 120 million a year actually this year already. It will go higher because of course it's linked to industry earnings, and industry keeps on earning more and more money. But collected by the Gambling Commission, administered according to strategic direction. I'm one of the people who sits on the advisory board for this, and I'm delighted to say that it is happening in a good way, with research receiving £20 million a year to distribute to all sorts of projects. Prevention, £30 million, and treatment is around £60 to £65 million. Now, treatment will not be only delivered by the NHS, of course. We will be dealing with gambling disorder. There are many people who score for gambling harms that are sub-threshold of 8 and below 8 on what we call a PGSI, problem gambling severity index. But on any other measure, if someone is experiencing harm and it's not a fully blown disorder, there are charities that the NHS will be collaborating with. There are also treatment interventions for families, support structures for families. All of this will be commissioned out by each clinic in relation to their regional collaborators. So it's all looking pretty good. The research side has to be absolutely independent of industry. We are working hard to ensure that that remains so. And in a year's time, I will be able to come back and tell you this has absolutely been successful and that we're addressing the right research questions. We have not as yet seen enough neuroscience for us to be happy about this at the moment, but I have great faith that we will eventually get there. As I've mentioned these sums, I won't go back on this. But what we really need in terms of prevention is to start to focus on harmful products and patterns of behavior. We need to understand health outcomes in relation to type of gambling. These are things that will be really important that we can now explore in relation to national data sets and also shared system data sets in relation to our clinics. A lot of the work on harm is done on population gambling rather than on people who have a problem, because that's a much smaller number. Laddie, how many minutes have I got? About 5? No idea. Okay, I'll just carry on until I'm told to stop. Okay, so a couple of things I really care about. Gambling advertising, there's no room for gambling adverts. There's no room for gambling in sport. And there is no room, I think, for harmful addictive products to be flooding our online sites or our high streets. So a lot of work has to be done, and we are committed to doing this as much as we can. I'll let Konstantinos talk about the NICE guidelines. Sam's mentioned the naltrexone. This is the first time I trained up some gambling doctors in naltrexone. That was a few years ago. Just the last couple.
Essie, you've got 2 minutes now.
I thought so. Okay, great. 2 minutes. That's perfect. So, stimulus control. Some of you won't know what this is. Do look it up if you're interested in gambling disorder. When we first started, we didn't have blocks on bank cards. We weren't able to do self-exclusion properly for our patients. There was no face recognition to avoid premises. We are somewhere else. We've used technology to fight tech gambling disorder, in a sense that most of our patients, all our patients, are online. So there are some interesting good things happening, and Gamban probably is the best of all. It's software that you install and no one can touch a gambling website if they've got it installed on their phone or their computer. So just hearing me say this might help you with some patients. Some books that we've done. This one is the latest, Breaking Free, How to Stop Gambling. If you're interested in this field or you want to work in it, read that book. And if you're still interested, there will be work ahead from lots of psychiatrists coming through. These are other books we've done. This is my email and my website. If you want to look at all the research papers, there's a long, long list of research done on really it's clinical research. Not only, there's also some international work on there. Thank you very much.
Excellent, brilliant, great timing. Thank you very much indeed, Etta. So we're going to move now to our next speaker, who's Mr. Steve Watts. Over to you, Steve.
Thank you. Can you just let us know that you can see
my slides? We can see your slides and we can hear you very well.
Lovely, thank you. Before I start, just want to pick up on a couple of points that Henrietta mentioned, and just thank her for mentioning the role of affected others. I think that's really important. Someone affected by somebody else's gambling, and that 6 to 10 people that are affected by somebody else's gambling just really sort of magnifies the problem. So thank you for raising that, and also the role of peer support as well, which hopefully I'm gonna talk about as well. So thank you. So my name is Steve Watts. I'm the founder of a charity called GamFam. I'm also the parent of a young man who gambled from the age of 16 through to about 20. He's 27 now. He's coming up 7 years in recovery in February. And when we reached out for support, there wasn't the clinics about in 2018, 2019, or we certainly wasn't aware of them. I also worked in education. I was a deputy head teacher in a secondary school. And I guess as a parent and as a teacher, I think I was fairly clued up about the dangers of drugs, alcohol, county lines, knife crime, that type of thing. But nowhere in my education, both personally and professionally, was gambling ever promoted as anything that could cause any harm. And looking back in my experience, my son left school at 16. He started at a football academy, and he came home to me one day and said, "Dad, how does a football accumulator work? All the lads at the football are doing it." And I always enjoyed a bet myself. And it was always a very low stake football gambling, maybe a day at the races once a year. So when he came home and asked that, I never really saw any harm in that. And I put his first bet on for him, which he won. He won 40, 50 pounds. And that was his start of his journey. And when I look back, would I have bought him cigarettes at that age? Of course I wouldn't. But there I was naively placing his first bet. But his journey changed from low stake football gambling to very quickly got moved on to the more addictive products. The online slots and casino and roulette was his downfall. So if I look at our experience as a family, our first port of call was to go to the doctors. And the doctor at the time didn't have any real understanding or knowledge of gambling disorder. And he put my son on sertraline to help manage his anxiety. We took him to the hospital where we felt that he was in the middle of a nervous breakdown. And once he turned 18, we wasn't allowed in with him if he didn't want us to be there. And again, there was a real lack of understanding back in the day. We also had the police involved on numerous occasions as well. And again, as great and as supportive as they were, that they said, "I'm really sorry, we don't really understand this. There's not really a lot we can do." We went to Citizens Advice for debt advice, and all we got was a leaflet on debt management. We never had a plan, and we was floundering as a family. And as it said in my intro, we stumbled into a peer support meeting. My wife and I attended our very first Gam-Anon meeting, and it was the first time that we found any real connection, any genuine empathy, and people who understood what we were going through, and it gave us that little bit of hope. So cutting a very, very long story short, we set the charity up just over 5 years ago, pre-COVID, and the idea was to do some outreach work, helping people understand what we'd gone through, and doing some peer support work in our local area. But once COVID happened, we had a big opportunity to take what we do now and work on a nationwide basis now. So part of what I'm going to talk about today is some of the work that we do. We've kept it simple at GamFam, and there's two real main strands of our work. One is the outreach work that we do. We're just in the process of launching our brand new Key Stage 2, 3 work, which is sort of early years, primary school, and then early years Key Stage 3, right up to Key Stage 4 and 5. We work in universities, and also we're just about to launch our new Gambling Harms in the Workplace program as well. So that's one aspect of what we do. And the other aspect is our online peer support groups that we run. And it's not just people coming on each week to the meetings, sharing their war stories and talking about the weather. We've got structure in what we do. We currently run 26 various different peer support groups. We've got 8 for recovery for those gamblers, and we've got another 18 for the affected others. That includes parents, partners, siblings, sons and daughters. We've just set up a brand new women's pathway as well. So that just shows you a little bit of a background, and we have a meeting every single day of the week for various aspects. We recognise and understand that we haven't got a magic wand at GamFam. We can't stop people gambling, and we can't stop people worrying about somebody else's gambling. And we work in partnership with our mental health partner, Suffolk Mind, and we use their wellbeing program. And we work on the basis that we're trying to help people meet their 9 emotional needs and 3 physical needs. And if the more of those needs they're meeting, the better their welfare is and the better their outcomes. And when you're supporting someone, talking from my own experience, supporting someone who's struggling with gambling disorder, we're not meeting hardly any of our emotional needs. So that's a really important aspect of the work that we do. We've got structure in everything that we do. We've developed a whole set of resources to help us give some consistency into the work that we do, which is based around the Suffolk Mind model, and also various topics and discussions, so that there is that structure in the meeting, as I say. It's not just all about coming onto the meetings. We've got a whole range of additional support that we run. We've got our online various joint meetings that we run. That happens sort of once a month. We have coffee mornings. We've just launched our brand new self-care retreat for affected others, and we've got different care and connect sessions, which is a lived experience support, one-to-one support for affected others. We've just launched our brand new GamFam Smart Start, which helps people meet their emotional needs and physical needs. And we're just in the process of launching our new online community, the GamFam support tool as well. Just a little bit more. We currently run 26 groups. I've spoken about the women's group. We've now held well in excess of 2,800 meetings, probably near at the 3,000 online peer support meetings. We've got over 350, it's about 340 at the moment, get support with us, and we've had well over 1,200 referrals. We carry out a quarterly survey of our active members using the Suffolk Mind Emotional Needs Audit. And something that's really important to us, we've just done our latest round of that. We do that 3-monthly check-in for those non-active members. And we're getting some really, really positive feedback about that. And it's important that some people drop out of support for various reasons. Maybe they've had a lapse, and those check-ins that we do bring people back into the fold and get people back into meetings, and that's a really important aspect of what we do. We contact all inquiries within 24 hours, and we get people onto a group within a week. We haven't got a waiting list. We produce a monthly newsletter which goes out to various professionals and all of our network to help people stay connected beyond the meetings. And something that we're really, really proud of is we've developed a CPD accredited facilitator training program. So all of our facilitators, all of the people that run our groups have been through our program, and they've got CPD accredited training. And I think that's really important because that gives us the consistency that we need. We've got a robust system in place for making and receiving referrals. We work with all of the NHS clinics, and we take referrals from a variety of sources, mainly through the NHS services, and through our website. We've had our yearly online celebration meeting, both online and in person this year. And next year, we're looking to develop that even further by developing the GamFam Roadshow, where we're going to take that model and sort of tour the country and hopefully connect our members in person so that when they do come online to their meetings, that connection is even greater. I think we spoke about those last two. So for us, we believe that peer support and the clinical support that the NHS clinics offer are not mutually exclusive and they can work together. We feel that our support can complement the evidence-based NHS support, and there's an opportunity there to improve that step up, step down approach. So if people come to support for us and then they need a bit of a top up or maybe a struggling slightly, we can then refer people back in. All of our members benefit from having sort of national coverage from all of the NHS clinics as well. We took a decision 2 or 3 years ago not to offer clinical support. We stayed in our lane and we concentrated on doing what we do well, and we work in partnership with many of the clinics. And I think if there's two asks that I would ask is that people get access to peer support earlier rather than at the end of treatment. And that model doesn't fit for everybody. But if there was asking you to take one takeaway from anything that I've said today, is to ensure that affected others are part of the recovery plan from the outset. So if you're speaking to anyone in a professional capacity, maybe trying to involve their parents, their partners, their families, their loved ones as well. And I think if we've got family members involved, then we can help maintain and sustain people in recovery for extended periods of time. I think I've probably covered most of that already. Just to give you an idea, as of the 31st of the 10th, we'd received nearly 500 referrals from the NHS clinics. You can just see the numbers there. And interestingly, the reason why I talk about this, before we started working with the clinics, I guess we were getting our referrals were 70% affected others and probably 30% gamblers. It's now based purely on the referrals we're getting from the NHS clinics, 80% recovery and 20% affected others. So I think that presents us with a massive, massive opportunity where we can start working with and incorporating the affected others in people's recovery plans. We've got lots and lots of testimonials, lots and lots of impact reports, which I'm going to talk about in a second. But one I always refer to is because the help and support that as a family we have received has been life-changing. So we've got families where we support the gambler, we support the mum and dad, we may support the partner, and we've also got the siblings as well. So often we're supporting more than one family member on different groups on everything that we do. That's not just me saying how great we are and the work that we do. We've got a whole series of impact reports that we've developed and we're constantly working on. So I talk about our work at Key Stage 2 and Key Stage 3. Those links between online gaming and gambling, I firmly think that's exactly where my son started. The hours and hours and hours that he spent playing FIFA, I think that's where he got that learned behaviour and that identification with spending money online. I spoke about our affected others self-care retreat. That's something that we're very, very keen to develop. And if you check out our website, we've got our GamFam impact reports and our evaluation. We've got a case study, the power of peer support, and we've got a couple of NHS feedback reports that we've commissioned with the Northern Gambling Service and also with the East Midlands. We would be delighted to be obviously doing one with yourself, Sam, with the Southern Gambling Service as well. And when we do our quarterly emotional needs audit, just one figure that we're extremely, extremely proud of is that our net promoter score is 92%. And we hear that anything above 70% is considered outstanding. And it's actually 97% on our affected others side as well. And that survey that we do with our members each quarter highlights that those people that have been in support with us for over a year are meeting their emotional needs 30% more than those that have been with us for less than a month. So we hope that we can measure the impact of our service and progress over time. If you are on the call and you are interested in making a referral to us, if you go onto our website, there's the useful information section. We would always encourage you to do a professional referral rather than a self-referral, because that way that hopefully guarantees the person that will be committed to the referral. So that's on the website under useful information. And when somebody gets referred into us, If it's someone in recovery, they'll speak to someone in recovery. If it's a female in recovery, they'll speak to a female in recovery. If it's a partner, they'll speak to a partner who's supported people. If it's a parent, they'll get to speak to me. And if it's a sibling, they'll get to speak to Beth, who's our operations manager, who's a sibling of someone who gambled. So when they do get referred into us, they're speaking to people who understand. Next steps, if you are interested, please do check out our website, and there's lots and lots of information on there. I'm going to leave my email up there, but just a couple of passing thoughts and for me to finish with, that I think our biggest challenge is helping those that have not been impacted by gambling harms understand that gambling can be problematic. Very much into protecting the next generation and supporting those parents to help them support their youngsters, recognizing and understanding the important role that peer support can play and how it can complement the clinical support that the NHS offer. And again, I will keep banging the drum for affected others. Affected others, I think, are crucial in helping and sustaining people's recovery. If anybody wants to take a bit of a deeper dive in anything that we do, please do contact me. I've got no idea how I've done for time there.
You've done brilliantly for time, actually, Steve. Absolutely spot on, perfect.
Right.
And thank you so much for that. That was excellent. Thank you so much. So I hope people will get, hopefully, if our speakers are happy to share the slides, you'll be able to get those details as well. And we'll make sure that we provide those details. I very much agree with Steve about that partnership approach, peer support, working collaboratively with statutory services. So our final speaker is Konstantinos Ioannidis, who I'm hoping is going to start his talk now. There you are. Hi.
Apologies, I need to unmute myself and try to share again. My apologies.
No problem.
So hopefully you will be able to see my slides. I want to say many thank you to Dr. Ioannidis Smith, Professor Subodhi Dave, and the very kind invitation from the RC Psych to do this talk today. I also want to say many thanks to the speakers before me, who very kindly presented all the work that has been done, and I'm grateful to be here. I will focus today specifically on the NICE guideline that was published earlier on this year in January 2025. And it would be a more matter of fact going through the guideline without much additional data or research, just going straight through the document and highlighting the key recommendations. My conflicts of interest, some research funds from European Horizon 22 program and NHR ARC Wessex, and an editorial statement from Elsevier, but no conflicts of interest related to the gambling or gaming industry. So the guideline NG 248 goes through the case identification, initial support, referral, and assessment for gambling harms, and it speaks about the information and support, models of care and service delivery, the treatment, relapse and ongoing support, and finally, least but not last, interventions for and support for families and affected others. So this is the overall outline structure of today's talk. The guideline starts by making a clear distinction between gambling that harms, which is the type or any type of gambling that causes harm or problems or distress to the person who is experiencing it, and to family, friends, and those close to them, also known as affected others. The other important term is gambling-related harms that refers to the adverse impacts of gambling. And as previous speakers went through, many of those I won't repeat here. The guideline covers people aged 18 and above and the affected others. And it puts stigma at the forefront of the guideline, paragraph 1.1.1, because stigma, shame, and fear of disclosure is an extremely important parameter to consider when we encounter people that experience gambling-related harms. It's very common that in the clinics, what we see is a person has put in a referral, and when we go through their clinical notes, we find that the person may have presented to clinical services for anxiety, for depression, for suicidality, or all sorts of different problems. But actually, gambling was the primary problem, but no one has thought about asking the question. Had that been done, say, a few years back, the person would have had the opportunity to speak about what's actually bothering them. So the guideline actually puts gambling as part of a holistic assessment, or part of the general health check. Do you smoke? Do you drink alcohol? Do you do drugs? Do you gamble? And if you do, are you worried about your own, or are you worried about someone else's gambling? To make people easier to talk about their gambling, if they say yes, encourage the person to complete the screening, like the PGSI. PGSI is not, by no means an ideal instrument. It has some weaknesses that's been known to the literature, but it's a good start. And as a screening instrument, if you score 8 and above, that you're likely to be experiencing gambling-related harms. So this is a good start to bring people to the attention of professionals. Where are the people? Where should we ask those questions? So the guideline actually casts a very wide net, and I have actually 2 slides on this because I think it's very important to see how wide the net should be. It starts from speaking about mental health contexts where the person presents with a mental health problem or concern. Maybe it's alcohol or substance use problem, especially cocaine. Maybe the person makes reference to gambling that harms in their family history. Of course, in neurology clinics where people manage people on Parkinson's disease or restless leg syndrome, and they take dopamine agonists, and we know that this is a common side effect of medication like ropinirole, rotigotine, pramipexole, or also aripiprazole, very commonly prescribed in psychiatry. Maybe in, again, neurological conditions with acquired brain injury that leads to disinhibition or increased impulsivity. But beyond the clinical settings, people who come across the criminal justice system or experience homelessness or share financial concerns or share safeguarding concerns, even just young people who have recently left home, as this is a very key demographic. And particular professions associated with high incidence of gambling. When we identify people with gambling-related harms, we need to advise them that support and treatment is available and recovery is possible. Inducing this therapeutic optimism is very important. It helps people more speak about their difficulties and seek out help. Signpost them to resources and services, and now we're very lucky to have NHS websites that guide people through different NHS clinics and other providers. Suicidal ideation and suicidal attempts is extremely important. Of course, we should never forget that those risk factors, and gambling is actually a modifiable risk factor. So if the person can manage to achieve abstinence, we can really change the trajectory of a person in respect to that outcome. Of course, signposting to relevant services at crisis point is very important. But there are practical things that anyone can do. You don't need a specialist NHS clinic to do some of those things. talk about self-exclusion techniques like gum ban or installing gum ban or gum stop on your devices, blocking marketing messages, which can be more complicated than it sounds, but also very important. Self-exclusion systems like Moses from multiple operators for land-based casinos or providers, working with banks to block gambling payments or general international transactions, as sometimes payments masquerade under other pretenses, or working with how you limit access to money for people. Wider considerations for financial, social support, employment or legal issues, and there are some excellent charities that do those things, and wider providers that support people. So highlighting those, linking people to those resources is extremely important. When it comes to assess gambling disorder, the guideline takes a very comprehensive view of how the assessment should look like. And I'm putting this very busy slide here, actually, to say that assessing people for gambling disorder in a holistic way is a quite complicated endeavor. It's like here, the guideline has a 17 bullet point, and many of the things that we need to be doing, like assessing person's medical history or comorbidities, physical health, diagnostics, the role of pharmacotherapy, either contributing or in recovery, is something that requires quite significant psychiatric competence. Other aspects like neurodevelopmental history or formulation require quite complex psychological competencies. So there's a big ask for training and for a workforce that is able to deliver this, which is very welcome. So we can all do a very good job about this very important issue. In our clinic, we have a 3 traffic light system for standard triage or complex with a medical angle, just to complement our staffing that delivers those assessments. And we put a lot of emphasis in the presence of lived experience. And we have extremely positive feedback on that end in our clinic. We need to provide people with unbiased information, specifically in regards to how support and treatment works, and also the role of industry. In terms of models of care and service delivery, of course, we have the multidisciplinary specialist gambling clinics based now at the NHS, and the wider services in the third sector and beyond that are currently undergoing a planned reconfiguration. But we need to think about the wider system, like social care practitioners working with the criminal justice system and voluntary sector organizations when it comes to treatment of gambling-related harms. This has already been touched upon, but there are 3 pillars to treating gambling. One of them, very important, is peer support. And peer support with lived experience should be integrated into gambling treatment services, including the NHS. We're very blessed to have that, but as far as I know, all the clinics do have that aspect in their works. As I said, very positive feedback on that end from our service users. The other pillar is psychological interventions with motivational interviewing, group CBT and individual CBT as the main 3 options. The dosage, as Sam mentioned earlier on, is a bit flexible at this stage, and a lot of research can be done to further refine those evidence-based treatment protocols. The third pillar is the pharmacological treatment. The guideline is currently supporting naltrexone as the only option. Of course, this is off-label use, as there are no licensed treatments in gambling in the UK or anywhere in the world. And there is a link to the National Prescribing Guideline, which have been we have been very lucky to have had a very good collaboration across pretty much all the NHS clinics to write that. So the role of naltrexone is effectively in relapse or with continuation of psychological therapy. So like in a shared pathway with psychological and pharmacological treatments. Moving on.
Konstantinos, you've got 2 minutes left.
Lovely. Moving on to the last bit, which is thinking about relapse and ongoing support. It's extremely important to recognize that that relapses, especially after the person has achieved abstinence, can be very distressing to the person, or may lead to suicide or self-harm. And we need to educate people that relapse is not shameful. Shame-informed care is an important part of how gambling services could structure a lot of these conversations, and so as not to additionally stigmatize the people that come to our services, indicate its relapse is not individual failure, reduce shame and increase confidence to the individual. Last but not least, with the great work that Steve and GAMFAM are doing, we're very blessed to have people like Steve and GAMFAM supporting our works. But this is a bit where the guideline makes specific reference for support for families and affected others. We need to give families the opportunity to receive help and advice, learn techniques to manage their own distress and prioritize their needs, and learn how to support their loved one in a using non-judgmental communication, which we know is what can help the person's recovery trajectory and help them achieve a holistic and robust, sustainable long-term recovery. But I'm going to stop there, and that's it. That's for me.
Excellent, excellent, excellent. So I'm going to ask all our speakers to put their cameras back on. And we've got lots and lots of questions. We're not going to be able to get through all of them. Steve has already started answering some of them. I'm going to say, Steve, we want to hear from you as well. But there's a couple of questions here. First question, there's from Mohammed Wajahat, but also Graham Broom has asked a similar question. And that is actually about the fact that there are multiple advertisements on social media, YouTube, streaming platforms, but also, frankly, on terrestrial TV, there are loads of adverts. And the question to our panelists is about their opinion regarding the appropriateness of this, the risks associated with this, and the politics and the money involved. And also, Graham has asked a similar question, which is about the fact that today marks the start of the Paddy Power World Darts Championship. And over half of Premier League teams are sponsored by gambling firms, which both highlight the, as he says, absurd level of gambling advertising in sport. Is there much progress being made in terms of gambling adverts being banned? And Steve, I'm actually going to ask you if you can start by telling us what your view is, and then we'll hear from our other panelists.
Well, my view, I think I've answered in the question. My view is that there is no place for gambling advertising. It should be treated exactly like tobacco. If I want to put a bet on, I know where to put a bet on. I don't want it rammed down my throat every minute of every day on every TV station. So the phrase permitted, not promoted, I think is important. And that includes free bets and offers as well. I think if you use the example, if you go into a supermarket and you want to buy some tobacco, it's behind shutters, no prices, but yet on the same counter is scratch cards. And I think for me, it's protecting the next generation. Our youngsters are seeing that advertising, and nobody could ever say that youngsters seeing gambling advertising is a good thing. So for me, it should be a complete ban on gambling advertising.
Thank you, thank you. Etta, could you say something about some of the work that's being done in this area, if any?
So it is a really serious issue. It's our next absolute goal. We needed the 15 clinics. We needed the levy. And the next thing is we need to ban all adverts. There's no room in this country for gambling adverts. There's no room globally, to be honest, because the minute you stop something here, it'll end up somewhere else where people are not as able to defend themselves. So I think It is extremely harmful. It has grown 20 years of new generations not being able to treat sport as sport because they all gamble or think about gambling. Young people particularly are being affected, but everyone is affected. I was horrified this week. Twice I turned the page in the Times to see an enormous lottery advert. That is not right. I will write in about that. It's disgusting, and not enough has been done because we've been so busy getting the place in order in terms of the levy and the clinics that we have not fought enough or hard enough against gambling adverts. But that's the next big thing. And I would predict, Laddie, that within the next 2 to 5 years, there will not be any gambling adverts. That I really believe that.
Yeah, that's really interesting. I mean, there are a lot of adverts on the telly, I have to say. Konstantinos.
Yeah, thank you, Lade. I wanted to mention a couple of things briefly. One is that in Australia, since this summer, but starting from this week, there's a ban on social media for under 16-year-olds. The European Parliament has been debating the same since the last 10 days. We don't have a formal confirmation of what will happen there, but it's indication that people are increasingly alarmed about social media and what happens to young people when they access many of these. We know that a lot of people, for many people, they access social media for fun and to follow sport, and then they are bombarded by gambling ads. And the white paper makes a very clear statement that they see young populations as particularly vulnerable, that require special protection, and that the current system does not provide that currently, specifically when it comes to online ads.
Okay, thank you. I think we're going to go to the next question because there's so many questions. But there are a few questions about aripiprazole, actually. And so there's a question about why aripiprazole causes, so it seems to be associated with gambling disorder. There's a question from Miriam Rodriguez about whether there's any evidence that cariprazine might contribute to gambling disorder in the way that aripiprazole does. And there's also a question about, because this is from Samudo Fernandino, who says aripiprazole is often prescribed as a mood stabilizer in mania and hypomania. Is the association with precipitating gambling behavior in this vulnerable patient population, is that something we should be considered, that should be considered prior to initiation? And should that be I suppose the question is, should that be a kind of warning on the product leaflet, actually? So I wondered if I think, Sam, you had your hand up first.
Thanks, Lade. Yeah, great questions. Probably the mechanism is through partial agonism of D2 and D3, dopamine D2 and D3 receptors in the brain. So cariprazine, yes, has also been linked to gambling disorder. It's interesting to bear in mind it's not only gambling disorder. So these medicines can also lead to a range of impulsive compulsive problems such as compulsive sexual behavior, compulsive buying. So probably it's acting on D2, D3 receptors in the brain to increase that propensity towards these kinds of rewarding behaviors. There's speculation about the exact mechanisms. There's a variety of competing ideas there, but it is speculative. In terms of prescribing, I wouldn't avoid using these medicines because they help a lot of people. But obviously awareness that they can trigger these kind of things, it needs to be discussed with patients. It needs to be weighed up in the risk benefit analysis. But really important is to let people know and to actually monitor. So if you're treating someone with these medicines, then keep an eye on these things. If they emerge, you can do something about it hopefully before the damage is too severe. So that will be the main message. I'll hand back to the chair now. Thank you.
Yes, I'm very keen to say something else. Thank you, Sam. Fully, obviously agree with everything you say. Just two things. Yes, the review is fundamental. The review so that someone makes time to check whether people's behavior has changed. And we do see compulsive sexual behaviors at times in gamblers because of the aripiprazole. But what I wanted to say is we have conducted a review of 343 patients of ours who, because of psychosis or other mental health issues, were prescribed aripiprazole, and then with a cause and effect ended up showing up at our clinic with a gambling disorder without having had one before. We submitted these 343 cards to the HMRA, and they have absolutely taken it very seriously, and the documentation is now in place to alert everybody about this being such a high risk. And this is only very recent, and we've also got a paper that is being accepted, so will be published any moment as well. It's very serious, and the thing that I'm most concerned about, and this will, we'll talk about how to evaluate whether people who started gambling pathologically to real extreme severity because of the aripiprazole, whether when you stop the aripiprazole can go into permanent remission, because I have not seen that clinically. I have seen people who continue to struggle or whose gambling goes down, but not fully. So it's a serious problem anyway.
Great, thank you. So I think I'm wondering about there are some questions about the timing and when it starts. And there's a question from Hiba Salem, who says, regarding gambling at school, it started from primary school, for example, raffle competitions. Is there something we can do regarding that, as all learned behaviours start from the early years? And there's another question, a similar question, around kind of youth. Jonathan Webster says, I wondered what your views were on loot boxes in video games. And these are games that are rated suitable for 3+ by the PEGI rating agency. Seems like to me a Trojan horse to encourage gambling in young people. And that's now been banned in Belgium. I'm really interested to hear what Steve has to say on that, first of all.
Well, if you look at the definition of gambling, a loose definition of risky behaviour for a desired outcome, that is loot boxes. So you're spending money, you pay real money to buy in-game currency, to buy an item from a loot box, and it is risky behaviour. The reason it's not categorised as gambling is because you can't take real money out of it. However, there are loopholes in that, and people can trade skins, and they've got currency with the people that are gambling. But for me, it feels and sounds a lot like gambling. I think it should come under the Gambling Commission, and it should be regulated as gambling. In our experience, that was 100%, in my opinion, is where that learnt behaviour was from my son. So yeah, I agree with the person asking the question there. They should be regulated as gambling, like they are in Belgium.
Okay. Has anyone else got anything they want to add to that? Konstantinos.
Just to say, completely echo Steve's thoughts. Loot boxes have extremely similar mechanics to gambling. And when we see people in our clinic coming forward with problems, gaming-related problems, but the problem is actually the financial problem from people buying repeatedly loot boxes and things like that, we just treat them as regularly, so they receive the mainstream treatment for gambling disorder.
Okay, can I just check something? So James Anglo's actually said, is there any evidence that children and younger people in the UK are more exposed to online gambling than in other countries? Or is it, how are we doing in comparison? Sam?
I'm not aware of any reliable comparisons because everyone's using their own metrics and methods, and we've got a lack of independent research for decades globally. But certainly, I think we can take our own experiences. I don't know about you, but if you look at where adverts are appearing, kids are saying this all the time, right? It's their favorite footballers, they're watching their sports, they're in the community, they're watching TV. The advert, they're on 24/7. And I think, obviously it's a little bit redolent of what we saw with Alco Pops, if you take my drift, that yes, legally the products aren't being targeted at children, but the design features of some of these products may be attractive to children. Let me put it that way.
Yeah.
One small piece, because you've already got a lot of information from the panel, but David Zendel has done some good research on the higher probability of gamers using loot boxes compulsively, ending up being pathological gamblers at 10 times the prevalence. So I think, there is a prediction there that if you get, now of course it doesn't have to be causative. It could be that you are exposed to gaming when you're younger. Loot boxes are what get you excited, and as you get older and it's permitted to gamble, you're gambling compulsively, and it's the finances and the rewards and the dysregulated reward pathways are playing a part in both stages of life. But equally, there's a very strong school that's saying that you are nurturing this dysregulated behavior towards risk early on, and that it sort of enhances the risks because of that. And both of those are very valid.
Okay. Konstantinos.
There are some very interesting global data in the Lancet Commission led by Heather Wardle that's been published, and it has some very interesting data, particularly from Africa, that show that there is a very high degree of penetration of gambling products, and it's worth reading if someone wants to know more about what's happening globally with gambling and the penetration of those products in the society.
Okay, brilliant. So a very, very, very timely question here from Deepak Swami. What are your thoughts or comments about the rate of gambling disorder comorbid in people with ADHD? Are there any studies to understand the difference in comorbid gambling disorder severity before and after treatment with ADHD medication? And there's another related question from, hold on a minute, just find it again. It's a bit further down. I'm going to find it in a minute. There we go. Gail Loveday. He says, I've been working in ADHD services and they've found that successful treatment of ADHD can reduce the risk of relapse alongside providing other support, including housing, etc. So what about ADHD and gambling? Sam and then Steve.
I'm going to let Steve go first, if I may.
Okay. All right, Steve.
Well, I'm obviously not a medical expert in this, but all I can tell you is the amount of people that we're seeing that talk about adult diagnosed ADHD, suspected ADHD, and the links with gambling. Now, what I hear from people with lived experience that are suffering with ADHD, they say that when they gamble, gambling helps them calm their mind. It gives them one thing to think on, and it helps them meet maybe some of their needs at the time. Obviously, once they've gambled for extended periods of time and they lost their money and they've come out of that gambling episode, then obviously there's the guilt, the shame, the remorse, the regret, etc., etc. But we're hearing so many people that are diagnosed with ADHD. It's coming through. There needs to be a longer term study with this, without a shadow of a doubt. But another just a point that I was speaking to a doctor, again, I've got no medical reference to this, just what he shared with me, that he said that the amount of time that youngsters are spending on their devices is rewiring the brain. So our 5, 6, 7, 8-year-olds that are using those devices are developing traits of ADHD. Jump forward to when somebody's 16, 17, 18. Well, I think we're sitting on a ticking time bomb. Maybe there's a connection there. I don't know. I'm sure there's people on this call that have got a more informed position than I have. I'm just looking at joining the dots up, and I think we've got a major issue on our hands.
Thank you, Steve. Sam.
Yeah, thank you, Steve. Yeah, I mean, there's certainly a big overlap in terms of comorbidity between gambling disorder and ADHD. So in one of the clinics that I run, I see people with ADHD and I see people with gambling, I see people with both. And there is a true overlap. I think there's also an issue with measurement where ADHD can be misdiagnosed. So there is a true overlap. But if you look at some of the literature, some of that overlap would be accounted for by using screening tools on particularly specific for ADHD, for example. So as to whether first-line medications for ADHD like stimulants would improve gambling, I think they would. It's not been well studied. There is some evidence that people with ADHD and gambling disorder have more severe gambling disorder. Logically, per one of the comments that was put from someone in a gambling service, it just makes sense that we know for ADHD, if you treat it, the risk of later problems with alcohol and substance use goes down. So I would also expect the risk of other impulsive problems to go down with that treatment, such as gambling. But again, that's based on personal clinical experience. It's not based on clear evidence yet. So yeah, I think it's just a really important overlap. And it's kind of it's often marginalized groups and people from perhaps sometimes disadvantaged backgrounds who are on these really long waiting lists as well. We've all heard about the chaos with ADHD provision. So you can imagine what that's doing to people where they've got both conditions. It's just a terrible situation to be in for everybody.
But clearly there's this research that needs to be done there, isn't there?
Yeah.
Anyone that interested in doing a PhD, there's your question. Etta, have you got anything to add?
Just that I envisage a regular portion of the £20 million a year to go to this, because of course there is a strong potential, if people are seen on time, diagnosed correctly, as Sam says, with the right assessment and treated, things may be prevented. The percentages are so high, both in the gaming clinic and the gambling clinic. We owe these patients a proper RCT with proper, prospective long-term outcomes.
Okay. So we've got 5 minutes. Well, actually, we've got 4 minutes. So this is just a quick. Hopefully, you'll be able to answer this one quickly. It's more of a technical question, and it's about naltrexone. And this is from. I'm going to lose the question now. It's about this is from Yuchek Chukwu Ugonabo. As a dopamine agonist and partial agonists have been implicated as potential causes of gambling, has dopamine antagonists, so dopamine blockers, been useful in the treatment of gambling? Any theory on how naltrexone's effect helps in the treatment of gambling disorder? Sam.
I'll try to be quick. It's a hard one to be quick about. Dopamine antagonist. There was some clinical trial data for one of the other antipsychotics, but it didn't come through in the network meta-analysis that Konstantinos did, so it's not very strong evidence. It's not well studied. We need to bear in mind that we've got the cortical dopamine and subcortical dopamine. So you could have a medication acting on one but not the other. Because, for example, if we enhance cortical dopamine, we might strengthen impulse control. In terms of how naltrexone is working, it's an opioid antagonist. So it's probably blocking the reward signal. I mean, this obviously it's a very crude way of trying to understand it, but just dampening the edge of reward when people are gambling or being exposed to gambling-related cues. That is a very quick answer to what is actually quite a complicated question to address, but I'll stop there. Thank you.
Thank you, brilliant. Etta.
Just to point anyone interested in this to the case series that we did. It was about 5 years ago, but it was a sequential 10 patients placed on naltrexone using various scales and telling their stories. And I think it's really worth reading if you're interested. Again, a massive area for RCTs coming on soon in terms of the levy funding for research.
Okay, so we're coming to an end. We've got two minutes, literally. We've got some fantastic feedback. But I would like each of you to say, what would be your one wish going forward? In 10 years' time, what would you like to see? We're going to do this starting with Etta, because Etta's been working longest in this, and then we'll finish with Steve. So Etta, then Sam, Konstantinos, and then Steve.
Thank you, Laddie. First of all, thank you again for the opportunity of being here with you all and having so many people listening to us. Well, I've been in this 20 years exactly, because it was 2006 when I used Nancy Petrie's original CBT protocols. I would say that for me, banning gambling adverts, removing gambling from sport fully across the whole country, with the support of the RC Psych, by the way, we can't go anywhere without you, will save lives and save people's future.
Thank you. Nice and succinct. Sam?
Etta's chosen the best one. I think that that's the most powerful thing that I think could make a massive difference. So what I'm going to focus on is all these funds coming through. What will be amazing is if in 10 years looking back we can say actually we made all this work independent from the gambling industry, and we stopped all the things that happened in the past where they were influencing research, policy, practice, politics. So that would be what I'd really love to see looking back 10 years from now. I'm hopeful about that, but clearly there's a lot of uncertainty.
Excellent. Konstantinos.
Thank you. So I will preface my wish with stating that we live in an era of AI and extreme technology capacity. And so in the background of that, my wish is that we create a system, a one-stop system that provides comprehensive blocking of devices and applications and physical land-based venues across the board that is user-friendly. It doesn't take much time or effort. People don't need to jump through various hoops to achieve that, and they are protected going forward.
Brilliant. And then finally, Steve.
It was a big question, but I would love to see the age permitted to gamble raised to 25. I think that would protect a whole generation of people.
Thank you so much. Those that just at the end there, absolutely brilliant. I just want to say thank you to our speakers, Professor Henrietta Bowden-Jones, Professor Sam Chamberlain, Dr. Konstantinos Ioannidis, and of course to Mr. Steve Watts. What incredible work we've heard about. This has been a real masterclass, and you've given us hope for the future. And it's amazing to see the difference that has been made and is being made. And I'm hoping that in 10 years' time will be a massive difference. And to all of those who are listening, thank you. If your question wasn't answered, we will get it answered, and we'll put it out there in writing. And Steve's already done a great job answering 3 or 4 of the questions. And of course, you will be able to get a recording of this session. It'll be with you in about a week's time. So that brings us to the end of our last Dean's Grand Round of the season. Thank you to all of you for attending. Thank you.
Thank you. Bye-bye. Thanks for inviting us. Bye-bye.
Thanks, Sam. Bye. Love you. Bye.